Welcome to this presentation on social work response to HIV/AIDS in the United States of America. We have with us Dr. Neil Abel of the Florida State University. He is a clinical social worker, has been working with HIV/AIDS and related issues since 1988. I now request him to make his presentation.
Thank you. I want to talk about the way in which professional social workers have responded to HIV in the United States in hopes that by examining the model which we have utilized, there can be some benefit and carryover to other cultural contexts. In the United States, we have been impacted heavily by the disease since the early 1980s and consequently have had some long period to develop our response. Within social work, we know that there are many roles and responsibilities that are within the purview of the profession. These include case manager, counselor, therapist, advocate, researcher, policy developer, and program manager, to name only a few. In each of these instances, we find that professional training benefits the social worker not only to have the knowledge necessary to understand the challenges posed by dealing with HIV, but also to cultivate the self-awareness that helps them to engage on a personal level in such a way that persons with HIV can be most usefully helped. In the United States, the first impact was among gay white men, and this turned out to be both problematic and beneficial. You may be aware that there was great stigma in the United States based on sexual orientation during that period. At the same time, however, in the early 1980s, we had just completed what was known as the Gay Pride movement. And in this context, many people had, quote unquote, come out of the closet in such a way that they were stating their sexual orientation and were very public and very well organized in their identity. This background permitted persons who already had other advantages by virtue of their characteristics and position in society, the fact that they were male, the fact that they were often white, the fact that they were very well educated and relatively advantaged economically. All of these things gave them a platform from which they could found groups such as ACT UP, or also the Gay Men's Health Crisis in New York, similar organizations throughout the country. And from this position, they were able to mount an aggressive approach to political, social, and economic change within society. This was not always well received, but the access that such persons had to power, to influence, to money, and the strength that they drew from each other put them in a position where they could unleash substantial efforts toward prevention and treatment, which have had benefits, arguably, for people worldwide. Currently in the U.S., in the third decade of the HIV epidemic for us, we find that a different population is now dominating the statistics. And these are increasingly persons who are poor, women, who are racial and ethnic minorities, and who very frequently are single-parent female heads of household. It is sadly not unusual for multiple HIV-infected persons to be part of the same household and for the complications that they face to thereby be compounded. Characteristically, such persons, in comparison to the earlier impact of the epidemic, lack wealth, they are not well organized, and consequently their political clout and sophistication isn't the same. HIV has increasingly become what we refer to as a disease of the poor. And as with all other circumstances which befall the poor or disadvantaged, it begins to fall out of favor. The second generation of men who have sex with men are persons who did not witness, characteristically, the deaths of many of their brothers, and consequently, having been spared that agony, they have now grown up in an environment where antiretroviral medications are broadly available and where they have a false sense of confidence that if they become affected, their illness can be easily treated and their suffering kept to a minimum. These circumstances lead to complications in the environment surrounding the response to HIV at this stage in history. One of the concepts that we have to contend with is called donor fatigue. And in donor fatigue, we find that people who previously would have given their money, their time, their resources, their names perhaps as people of influence or celebrity to HIV are beginning to move on to other illnesses where they feel either that they can be more hopeful about short-term change or simply to something which captivates their interest in a novel way. And so while these causes are very deserving, breast cancer being very high among them, for example, the consequence for persons with HIV is sometimes a reduction in access and support. We also find that we have an increasingly fundamental conservative movement in the United States. This is typically inclusive of people who are strong in their conservative or fundamentalist faith, and from that standpoint place emphasis on what are referred to as family values over public health, stressing monogamy exclusively without regard for the fact that many people find monogamy unfortunately not possible for them due to the unfaithfulness of their partner. This conservative movement has had an impact on the forms of education that are made available and has tended to stigmatize people who deviate from the moral or social norms that this movement espouses. Emphasis on abstinence only, which has been front and center in the PEPFAR initiatives, the President's Emergency Response Program for HIV and AIDS, have minimized the capacity to include information on safer sex and condom distribution and have limited the avenues open to social workers as they respond. Therefore, social workers have a number of implications, including the need to maintain their stamina and commitment to persevere with traditional high-risk groups. We're having to return our attention to men who have sex with men, even though many had thought that that group now had put the problems behind them. We're having to continue to strive for inroads in public schools so that we can provide children with the education they need, especially as they move into adolescence and beyond and become sexually active, specific, clear information that will help them keep themselves safe. We have to develop advocacy skills to provide that voice for the voiceless and to educate people within disempowered communities on developing organizational skills and learning to effectively speak for and lobby for themselves. Social workers need to engage with the religious and spiritual leaders in their communities. And in doing so, taking a tack which is exclusively oppositional is not only unwise, but probably counterproductive. Instead, we need to learn to work respectfully with such leaders, understanding the basis for their positions and values, and encouraging them to cultivate the compassion on which all faiths worldwide are ultimately founded. Finally, we need to raise awareness of our own strengths and limitations in the front line as HIV educators. Sometimes social workers have to wisely take a back seat and be behind the scenes, helping others do the visible prevention education while we provide support to them in the background. Treatment in the United States is largely funded by the Ryan White Care Act, which was originally developed in 1990 and which was named for a young white male who was deemed to be innocent because he had contracted the virus through a tainted blood transfusion. Because he could not be stigmatized as gay or as being a person of color or in some other way out of favor with the mainstream in the society, advocates wisely made him what is otherwise known as a poster child, and using his innocence as a frontline image, were able to persuade the Congress to fund a broad range of services which are administered to serve outpatient care, primary care, and a wide range of community-based services administered individually by each state. This has the benefit of allowing each state to tailor the use of monies to their own specialized needs, but has the potential downside of permitting states to make budget decisions which may ultimately disadvantage some of the people who are most in need. Means testing means that eligibility must be established on the basis of poverty and disability before people are fully entitled to receive Ryan White CARE Act funding. The AIDS Drug Assistance Program, which is the primary funding mechanism to provide antiretroviral medications and medications for the treatment of opportunistic infections, currently serves 95,000 people in the U.S., and social workers help to educate patients about the medications that their doctors have prescribed. For those persons, some 2,000 at this stage, who are currently on waiting list for these medications due to shortfalls in commitments for funding, social workers also become a front line of support, trying to help them as they struggle through these periods. We have legislation which is very useful in principle, and like all social policy, it is only as beneficial as it is put into actual practice. The Health Insurance Portability and Accountability Act is designed to reinforce confidentiality and to ensure the privacy of patients' medical records. The American with Disabilities Act is designed to guarantee access to housing, employment, education, and a full range of social benefits without regard for disability or illness. Collectively, these components safeguard civil liberties and provide a legal basis for protecting the rights of persons infected. However, with 45 million people in the United States lacking health insurance, we find that there are many gaps in the network that we have developed, the safety net, to keep people from falling too far down in the illness cycle. The New England Journal of Medicine in July of 2005 has documented what many suspected regarding disparities based on race and ethnicity in life expectancy, access to health care, and severity of illness, with black women bearing the greatest burden. Our Senate Majority Leader, Bill Frist, a cardiovascular surgeon, failed to answer correctly when asked 3 times on national television whether saliva or tears could transmit HIV, which of course it cannot. As the leading physician and the most visible such person in the country, one would have hoped for a better answer in that context. So again, implications for social workers. We need to be aware that medical advances can only succeed when they are both understood and trusted. We have the need for ongoing education of providers across the full spectrum to make sure that what we have available to us factually is translated into useful and understandable language for people in all segments of the care spectrum. Providers need to be reminded frequently of AIDS 101 so that, unlike Senator Frist, they will be able to clearly distinguish HIV myth from HIV fact. We need to continually monitor the access to and adherence to medications, and social workers play a very important role in supporting patients to have positive relationships with their doctor and to interpret the information that they gain from them during medical sessions. And finally, social workers need to be aware that our constituents are not only persons living with HIV/AIDS. Our clients include their families healthcare providers, community and religious leaders, and also politicians. And if my remarks have had an aspect of critical judgment in them, it's important for even me to remember that approaching such persons without due respect and regard for their points of view will be very detrimental to our ultimate success as social workers. In the U.S., end-of-life issues are very controversial and represent, on the one hand, a very well-developed body of social policy and also an area of great controversy. We have available many facilities for care, comfort, and support. And one of the great strengths of the hospice movement in the United States is its emphasis on palliative care. When a patient has declined to take more treatment to cure opportunistic infections or disease, and instead is asking only for comfort, having reconciled themselves with the end of life, hospice workers have great skill in alleviating pain and using medication to minimize suffering, not only for the patient, but for the loved ones and family who have to observe their condition. Advance directives serve as legal documents in the form of living wills to express the wishes of patients at the end of life, healthcare surrogate documents wherein they can identify a person who they hope will be responsible for expressing their wishes at the end of life if they become incapacitated and are no longer able to speak for themselves, and do not resuscitate orders, which ask that medical technology be unutilized to artificially sustain life when it is clear that the end is at hand. The right to die and the right to life movements in the United States have been in long-standing, and now in particular, at this moment in history, very clear and vivid conflict. We see that the case of Terry Schiavo in my own home state of Florida became the focus of international news when first Governor Bush and later his brother President Bush both attempted to intervene against the wishes of the husband and in favor of the wishes of the parents of Terry Schiavo, who had been increasingly ill for a period of 13 years. Failure to express her wishes clearly in writing led to great confusion in managing her conditions at the end of life. Persons in a position to provide care at the end of life, whether they be formal caregivers like the social worker or informal caregivers like the family member, need to be supported in all of the levels indicated in this slide. We need a comprehensive approach with them so that we can walk with them in their time of suffering. And for social workers, this is where self-knowledge becomes so critical. We must have an understanding of how to be with people in their time of need without imposing on them our personal or even our professional wishes. So that in the end, when facing this most critical stage in the life cycle, we have to redefine success as the alleviation of suffering, not cure. And we have to support one another as social workers in our capacity to embrace grief and mourning and to work with families and professionals so that, as we see in this panel from the AIDS quilt, we can stand together with one another, not only to mourn those who have passed, but also to celebrate the beauty of their lives and to remember that a person with HIV is deserving of full dignity and respect throughout their illness and even after death.
Thank you, Dr. Neil Abel, for your wonderful presentation on social work response to HIV/AIDS. It was very informative, highly motivating, and an eye-opener for young professionals in this country. Thank you.